Perfect. Not perfect. Now we're perfect. And then it always messes up. Where my slides at? What? Okay. Principles of pharmacokinetics. So as the medication administered in the body begins moving and removing the medication from the body, duration and effectiveness of the medications are determined by your dose, your route of administration, and your clinical status of your patient. Pharmacokinetic section of the medication profile states of the following. The onset is related to the absorption distribution. Peak is related to the absorption distribution. And duration of effect is related to the medication metabolism and elimination. So as the amount of medication near the cell receptors decreases, the effects begin to decrease. As a medication permanently binds with the receptor site or irreversibly alters the functioning of a cell, the duration is determined by the body's ability to regenerate cells. So our routes of medication administration must be capable of delivering the appropriate amount of medication in the correct locations of the patient's body. It's determined by the physical, chemical properties of this medication and the routes of medication available for a patient. So how quickly these effects are needed, it depends on the bioavailability, the percentage of the unchanged medication, and the reaches of the systematic circulation. It's determined by the routes of administration, varies by the medication except for the IV route, and the IV route has 100% bioavailability. So that's typically the route that we always want to make sure that we're going whenever we are administering. It's irrelevant for medication to be sequestered by the GI tract. So you have different features such as oral, orogastric tube, nasogastric tube. You can also put medications through these routes. And then a large number of medications are administered through the GI tracts. Patients must be responsive so they don't choke, must be available to swallow and have a nasogastric tube or gastric tube inserted. Once administration, the medication absorption can vary. So GI medications can be subject to first pass metabolism. I don't know why it's hard to say that word. Metabolism occurs in the liver and alters the potential and inactivates the medication before it reaches the systematic circulation. So metabolism is also can occur within the GI tract. Patients with liver dysfunction of these medications are at risk of toxicity whenever they dysfunction. So endotracheal, we know that it's not considered a reliable method for medication administration. If endotracheal medication must be given, it should be given at least 2 to 2.5 times the IV routes, because a lot of that acid in your stomach is going to destroy it. Followed by a 5 to 10 milliliter flush of sterile water or an almost saline solution to make sure it doesn't get stuck in your esophagus. Intranasally, so liquid medication can be converted into a mist that's sprayed into one or both nostrils. Absorption is rapid. We use this for Narcan a lot. And bioavailability is close to 100% at certain studies. There's no risk for a needle stick or injury to the paramedics, so that's one of our benefits that we get. Intravenous is preferred method in the pre-hospital setting. A small diameter catheter is inserted into the peripheral external jugular veins, typically 18 gauge, maybe 20 gauge. Medications administered directly into a systematic circulation. Bioavailability is around 100%. The onset is quicker than the medication given orally through the orogastric or nasogastric tube. Limitations include any of the following. So several types of patients who have abused IV drugs, patients in profound shock, patients with cardiovascular collapse, and patients with certain chronic medical conditions. The procedure could cause pain, infection, and is time consuming. Certain classes such as sympathomimetics can also cause pain and tissue damage. So a needle that's inserted into the patient's skin and into the bone, we have vascular uptake from the bone marrow that provides a reliable route for medication and IV fluids. Any medication that's administered by IV can be administered intraosseously as well. it can generally be left in place up to 24 hours. Contraindications would be that the bone's fractured. There's not really a strong connection to the rest of the body there. So it's discouraged when patients have bone disease or a skin infection over the infection site if doing intraosseous. Intramuscularly is steroids. If a steroid medication is injected in one of the patient's larger muscles via the glute or the tricep, it's used when IV access cannot be established and when the clinical situation requires immediate medication administration, such as glucagon. And medication bioavailability is 75% to 100%. So there's risk of contaminated needle stick if the patient moves suddenly, and it confirms the following. The medication is appropriate for IM use, particular muscles should be used, and particular techniques for injection should be used. Subcutaneous, this is through a even smaller gauge needle. You're just going to pinch the skin and insert it at roughly like a 30-degree angle. It's going to disperse it through the skin, not through your muscles. Dermal, transdermal, nicotine patches, analgesics. It's just a patch that goes through absorption to the skin. Sublingual is under the tongue, such as nitro tabs. If someone's having a heart attack, you can put nitro spray or nitroglycerin tabs. I use supplements like, what is the mushroom? Lion's mane. Put lion's mane sublingually. Lack of saliva could delay absorption. Patient must be conscious so they don't choke. Inhaled and nebulized, this is going to be like your albuterol spray, atropine spray that asthmatics are going to use. That way it can bronchodilate. It's going to open up the pipes that go into the lungs so the patient can breathe better. Keeps them from wheezing. And this is with nebulized medication. Then there's rectal. You can shove it up their ass. Ophthalmic, so eye drops, carries possibility of systemic toxic side effects. Hemodialysis, when blood is pumped through a dialysis machine, exposing the blood to diacetyl solution before returning to the patient. And then in hemodialysis is the dialysate solution that removes toxins and excess electrolytes and other chemicals. Training. I want to get into some of the medications. Osmosis is used to enhance the distribution of certain medications. Allows IV fluid to leave the intravascular space and enter various tissues. Filtration, redistribute water. Epithelial cells create a continuous barrier that are contained in the skin. GI tract, eyes, urinary tract. I want to get to the names of these. Alright, so when we're giving a medication, we're going to call out the medication name and dose prior to administration. Unlabeled syringes pose a significant hazard in healthcare. And then whenever possible, we're going to use pre-made stickers on handwritten labels that indicate the least medication's name, concentration, and if the medication is intended to be administered immediately. Patient safely exerts and is recommended building an environment in which the EMS provider feels comfortable and often referred to as just culture. This table. Misinterpretations. So 4 milligrams could be misinterpreted as 40 milligrams. 0.8 could be misinterpreted as 8. Morphine sulfate and magnesium sulfate. That's a common misinterpretation. And then magnesium sulfate could be morphine sulfate. Subcutaneous, sublingual, those can get mixed up and jumbled. And then intramuscular versus intranasal versus intraoscular. Maybe not. Oscular is pretty obvious. Alright, so we have drugs that act on the sympathetic nervous system. Um, Receptor sites exist in the body that are connected to the cell through the body. So receptors are activated by chemicals, whether naturally occurring or in the form of a medication. Drugs that influence the sympathetic nervous system are classified according to the receptors in which they interact with. So in a sympathetic nervous system, receptors are labeled alpha and beta. Any beta agent is going to increase the heart's rate, force, automaticity. So everything regarding the heart is going to be a beta agent. Arteries have receptors for alpha and beta agents. An alpha drug will cause vasoconstriction. A beta agent is going to cause vasodilation. The lungs have alpha and beta receptors. Alpha agents can cause minor bronchorestriction, and then beta androgenic agonists trigger significant bronchodilation. So drugs that have alpha or beta sympathetic properties are called sympathomimetic drugs. So we have alpha and beta receptors, and then on the arteries, alpha as well. If we go back, what do we got? Okay, beta and alpha, beta 2 and alpha, and then beta 1. So 2, think of 2 lungs, beta 2 receptors, and then alpha receptors. Beta 1 receptor on the heart, you have 1 heart. Beta receptor, alpha receptor, you have alpha receptors on the arteries. So think of the pulmonary artery. So this figure shows the effects of the alpha agents on the sympathetic blockers of the heart. So basically, if you have an alpha receptor that hits the heart, it's not going to have any direct effect because the heart isn't alpha 1 on the lungs. You need a beta 2 or alpha. Not sure what that is. And then vasoconstriction on the arteries, we are going to be able to plug in there. What is this? Alpha receptor. So yeah, alpha receptor, not on there. Alpha does work on the lung. Alpha does work on the artery as well. Beta sympathetic agents can be classified into 2 groups based on the subtle differences between the beta receptors in the heart and the lungs. So alpha receptors, we have phenylephrine or neosynephrine, norepinephrine, bitartrate, levophed, and dopamine. So alpha and beta, depending on the dose, that's going to be our dopamine. Beta is epinephrine, albuterol probentyl, beta 2 specific, isoproterenol or isoprel, pure beta specific. So beta 1 androgenic, beta 2 adrenergic agonists. I'm trying to make sure this dopamine, I think this dopamine goes with alpha or beta.